Hello everyone, in this class we'll try to understand about the physiology of pain. Learning objectives of this class would be to define and classify pain, name the nociceptors and give their distribution and properties, draw label diagrams of pain pathways, list the differences between somatic and visceral pain, define referred pain and understand its theories, understand the mechanism of pain recognition and perception, and describe the endogenous analgesic systems. Generally, pain is the earliest indication of morbidity. Physiologically, pain is protective phenomena of the nature. The experience of pain with or without disease is almost universal. Pain, either due to punishment or due to natural injury, leaves a scar in the memory. Pain is expressed in different terms and languages. Usually it is described like throbbing, burning, piercing, excruciating, lacerating, aching, etc. However, often it is difficult to describe the exact feeling of pain. It is said that pain is better felt than expressed. Pain is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. This is the definition of pain given by International Association of the Study of Pain. What are the different nociceptive stimuli? Stimulus that elicits pain is called as noxious nociceptive stimulus. Nociceptive means the one which is potentially damaging. Thus, stimulus that is capable of damaging or causing harm to the tissue is a nociceptive stimulus, and the sensation elicited is often called as nociception or pain sensation. Nociceptive stimuli are different for different tissues such as listed below. For the skin, the pricking, cutting, crushing, burning and freezing, whereas for GIT, the inflammation of the mucosa, distension or spasm of the smooth muscle and traction of the mesenteric attachment can cause pain. In skeletal muscle, the ischemia, necrosis, hemorrhage, injection of irritant solutions and injury of the connective tissue sheath can cause pain sensation. In cardiac muscle, ischemia or inflammation of the muscle can lead to pain. In joint, inflammation of the synovial membrane, exposure of the synovial membrane to hypotonic solution and stretching or tearing of ligaments around the joint can lead to pain sensation. For blood vessels, artery or vein pierced by needle, inflammation of the artery or vein, obstruction of artery or vein as occurs in the thrombotic or embolic occlusion, and excessive arterial pulsation such as it is seen in migraine, etc. can lead to pain in the blood vessels. In brain, traction of the cerebral arteries or meningeal structures can lead to pain. In nerves, compression of the nerve root or sensory ganglia, and pain in the intraneural lesions arises from the sheath or nerves can lead to pain sensation in the nerve. There are different types of pain. It could be fast or slow pain. A pain stimulus first elicits a sharp localized pain which is followed by diffuse dull pain. The first component is called as fast pain or the first pain, and the second component is called as slow pain or second pain. The fast pain is transmitted by A delta fibers and the slow pain is transmitted by C fibers. There can also be superficial pain and deep pain. The pain elicited in the superficial structures like skin and subcutaneous tissue is superficial pain, and it is usually the fast pain. The pain felt in the deeper structures like bone, muscles, connective tissues is deep pain. The deep pain is usually slow pain that occurs due to the stimulation of the C fibers in the deeper structures of the body. Then there can be somatic or visceral pain. The pain originating in the somatic structure is somatic pain, and pain originating in the visceral structure is visceral pain. Then there can be peripheral or central pain. The pain occurring due to the direct stimulation of the receptors or nerve in the periphery is called as peripheral pain. Example, it is a neuropathic or neurogenic pain as it is seen in neuralgias. Stimulation of the central pain fibers resulting in pain is called as central pain. For example, central pain in the pain below the level of lesion in the spinal transaction. Then there can be physiological pain and pathological pain. It could be acute pain or chronic pain, or neuropathic pain or inflammatory pain. The acute pain is sometimes referred as a physiologic pain. Acute pain has a sudden onset and subsides faster with the natural healing process or due to treatment. It is called physiologic pain or good pain as it serves an important protective mechanism. Chronic pain, often referred as a pathologic pain or bad pain, as it persists even after the healing from injury or following treatment, as usually they do not respond to usual anti-inflammatory analgesics. There are two categories of pathologic pain, that is neuropathic pain and inflammatory pain. The neuropathic pain is due to the nerve damage as it occurs in chronic diabetes, ischemia, or because of the toxins. And inflammatory pain is due to the inflammatory diseases such as rheumatoid arthritis, and usually inflammatory pain is accompanied by hyperalgesia or allodynia. The receptors for pain and the peripheral fibers. There are different types of nociceptors. The receptor for pain are they are called as nociceptors. Nociceptors are mainly the free nerve endings. They are distributed widely throughout the most parts of the body. However, there are few tissues like brain, only the neural tissue in the brain, that are devoid of nociceptors. Though the brain tissue does not contain nociceptors, the coverings of the brain are rich in these receptors. The nociceptors are broadly divided into three categories. There are A delta mechanical nociceptors, multimodal C fiber nociceptors, and other types of nociceptors. A delta mechanical nociceptors, these are terminals of A delta fibers. The A delta fibers are small myelinated axons that discharge only in response to intense mechanical stimuli, but not to thermal or chemical stimuli. The fibers are usually 1 to 5 mm in diameter with a conduction velocity of 10 to 30 meters per second. A delta fibers, they usually conduct fast pain. Polymodal C Fiber Nociceptors. The polymodal nociceptors are activated by high intensity mechanical, chemical, and thermal, both hot and cold stimuli. As they respond to varieties of stimuli, they are polymodal in nature. These terminals of C fibers, which are fine unmyelinated fibers having diameters of around 0.3 to 1.2 millimeters and conduction velocity about 0.5 to 2 meters per second. The fibers of nociceptors usually respond to the thermal and chemical stimuli. They respond to high skin temperature, at least 45 degrees Celsius, and locally applied chemicals. The C fibers carry the slow pain. The other nociceptors, these includes thermal nociceptors. There is A delta and C fiber terminals that responds to very low and high temperature, that is less than 5 degree and more than 45 degrees Celsius respectively. A delta fibers responding to heat, and non-multimodal C fibers responding to strong mechanical stimuli. There are three types of receptors for thermal pain have been cloned. The first one is cold and menthol sensitive receptors, which are called as CMR1. The second one is VR1 receptors, and the third VRL1 receptors. Number 2 and 3 are vanillinoid receptors for nociceptive heat that are sensitive to vanillins, a group of chemical substances including capsaicin that induce pain. Vanillinoid receptors at C fiber terminals have been described recently. These receptors are so named as they respond to vanillin, a group of pain-producing compounds that include capsaicin. The VR1 responds not only to nociceptive stimuli such as capsaicin but also increase in the temperature more than 43 degrees Celsius and change in the pH also. Another type, which is called as VRL1 receptors isolated from C fibers, respond to temperature above 50 degrees Celsius but not to the capsaicin. Thus, it appears that there are multiple receptors in C fibers ending responding to various stimuli, or possibly they may be different C fiber systems. The TRP family and ion channels. The CMR1, VR1, VRL1 receptors belong to transient receptor potential family of ion channels. These are excitatory ion channels. Especially VR1 has a PIP2 binding site. When the quantity of PIP bound to VR1 is decreased, the sensitivity of this thermal nociceptor is increased. However, the mechanism of action of these receptors is fully understood. In general, depolarization in the cutaneous receptor could be due to the inhibition of potassium channels that decreases the potassium efflux, or activation of the sodium channels that cause sodium influx or inhibition of sodium potassium pump. Depolarization of cool receptors is observed to be due to the calcium influx. Then the termination of these pain fibers in the spinal cord. The cell bodies of the pain fibers are located in the DRG. The fibers enter spinal cord via dorsal horn. In case of cranial pain fibers, the afferents project to the nucleus of trigeminal nerve in the medullary analog of the dorsal horn. In the dorsal root, pain fibers occupy the most lateral part of the root. In the dorsal horn, A delta fibers terminate in lamina 1 and 5, and C fibers terminate in lamina 2. In spinal cord, the ascending pain fibers occupy the lateral fasciculus. However, the thinnest pain fibers, that is C fibers, from discrete bundle in the spinal cord, the tract of Lichier. So they are going to form a discrete bundle in the spinal cord, which is called as tract of Lichier. The Lichier's tract is also contains a deep sensory and propiospinal fibers. Then specificity of nociceptors. Many theories have been forwarded to explain the specificity of nociceptors and nociceptive pathways. These are specificity theory. This theory states that the pain sensation has a specific sensory modality, specific receptors, and specific pathway in CNS. Stimulation of these receptors and pathway produces the sensation of pain. Overstimulation theory. This theory explains that the pain results from overstimulation of various types of afferent endings. Therefore, according to the overstimulation theory, pain can be transmitted via different afferent pathways. The pattern theory. This theory states that the pain sensation can be elicited by stimulation of receptors by a particular pattern. However, finally it has been agreed that the specificity theory explains all these aspects of pain. Thus, the receptors for pain are specific and also the pathways. Dermatomal distribution of the pain fibers. Pain fibers are distributed in the somatic structures as per the sensory map of the body, which is useful for the physician to locate the site of lesion. The distribution of pain fibers from deep structures, however, does not fully correspond to the cutaneous pattern, though they also have a segmental pattern. For example, T1 to T4 nerve roots mainly innervate the thoracic organs like heart and lungs. T6 to T8 nerve roots for the upper abdominal organs, and T10 to T12 nerve roots are for the lower abdominal viscera. The pain is localized like other sensory modalities. sharp pain is better localized than the dull pain because it preserves its specific dermatomal representation and also somatotropic organization in the central nervous system. However, in general, pain is relatively poorly localized because pain endings have low innervation density and pain pathways exhibit extensive branching than the other sensory pathways. Visceral pain is very poorly localized than somatic pain due to less number of receptors present in the visceral structure and also due to their poor cortical representation. Coming to the pain pathways, the pain is transmitted to the higher centers in the brain in the lateral spinothalamic tract of the anterolateral system. The pain pathways are divided into two types, the paleo-spinothalamic pathway and neo-spinothalamic pathway. Paleo-spinothalamic pathway phylogenetically is the oldest pathway. So this pathway mainly carries the sensation of slow pain. This is the slow conducting multineuron system that mediates poorly localized pain from deep stomatic and visceral structures. The fibers are mainly the C fibers. The first order neuron enter the spinal cord and terminate mainly in the lamina 2 of the dorsal horn. The second order neurons decussate and ascend up in the contralateral spinothalamic pathway. The fibers are more medially placed than they are more medially placed in the spinothalamic tract. In the brainstem or in their way to the thalamus, fibers project to the three major nuclear groups forming three subsystems. At the level of medulla, the collaterals from the second order neurons heavily project to the reticular formation. Therefore, this pathway is also called as spino-reticulothalamic pathway. The fibers also project heavily to the midbrain nuclei, that is spinomesencephalic fibers like midbrain reticular formation, parabrachial nuclei and periaqueductal gray. Fibers also project to the hypothalamus forming spinohypothalamic fiber system. The third order neurons from the thalamus, they terminate mainly in the medial nuclear group, that is the midline and the interlaminar nuclei are also called as non-specific nuclei of the thalamus, from where the third order of neurons arise and project to different areas of cortex including limbic cortical areas. The special features are because of the non-specific projection of the paleo-spinothalamic fibers that mainly transmits slow pain. The slow pain is poorly localized, and through its substantial projection to the reticular formation, the slow pain keeps person awake. Also, though its connection with the limbic system, paleo-spinothalamic pathways evokes the emotional experience of the pain, and through hypothalamic connections, it mediates autonomic responses. So this pathway mediates motivational effect component of the pain. So thus the paleo-spinothalamic pathway mediates arousal, affective aspects and autonomic responses of pain. Coming to the neo-spinothalamic pathway. So the neo-spinothalamic tract is most developed in primates. This pathway carries mainly the fast pain. The fibers are mostly A delta fibers. The first order neurons terminate mainly in the lamina 1 and 5 in the dorsal horn of the spinal cord. The neurotransmitter released at the terminals of the primary nociceptive afferents, that is from the first order neurons, are glutamate and neuropeptides, of which most important is substance P. So this diagram showing how the C fibers and A delta fibers, they are going to relay in the spinal lamina. C fibers, they mainly relay in the lamina 2, whereas A delta fibers, they are going to relay in lamina 1 and lamina 5. Second order neurons cross over to the opposite side in the same segment of the spinal cord and ascend in the lateral spinothalamic tract. In the spinal cord, so there is a topographic organization of the fibers. The fibers from the lower body parts are placed laterally, and fibers from upper body parts are located more medially in the lateral fasciculus. The fibers from sacral spine segments occupy the most lateral part, and the fibers from cervical region are present in the most inner part of the spinothalamic tract. The second order neuron terminate at the lateral nuclear group, that is ventrobasal and posterior nuclear complexes, are also called as VPL nuclei or specific nuclei of the thalamus. In their way to the thalamus, the neospinothalamic tract projects sparsely in the midbrain reticular formation and periaqueductal gray and hypothalamus. The third order neuron originate from the specific thalamic nuclei and project to the postcentral gyrus, that is the somatosensory cortex. The topographic organization of these fibers in the thalamus and the cortex are very concrete, and in the sensory cortex the neurons are organized in modality specific columns. Therefore, the fast pain is better localized. Special features of this tract are the topographic organization of the neospinothalamic fibers in the thalamus and cortex is very concrete, and in the sensory cortex the neurons are organized in modality specific columns. Therefore, the fast pain is better localized. The neospinothalamic pathway, for its termination in the specific and discrete areas in thalamus and cortex, subserves the sensory discriminative aspects of pain, that is the localization of the pain and detection of quality and intensity of noxious stimuli. Okay, here the pathways showing the difference between the fast pain, that is paleospinothalamic tract, and the paleospinothalamic tract and neospinothalamic tract. Okay, so if you observe the paleospinothalamic tract, from here the second order neurons, they are going to arise, and they are going to give collaterals to the reticular formation, periaqueductal gray, hypothalamus, and in the thalamus they relay in the non-specific areas. Okay, and again from the thalamus they diffusely go to the different areas of the cortex, whereas the neospinothalamic tract, okay, so which is carried by A delta fibers, they're going to go to the specific neurons of the spinal cord. Usually they're going to relay in lamina 1 and 5, okay, and then they ascend in the opposite spinal cord, where they give less collaterals to reticular formation, periaqueductal gray or hypothalamus, and in the thalamus they are going to go to the very specific part of the thalamus, that is VPL nuclei, and then they are going to go to the specific part of the parietal cortex, that is area number 3, 1, 2, and with a topographical representation. And this is how the spinothalamic tract and the dorsal column fibers, they are situated. The dorsal columns, usually the sacral fibers, they are situated medially, and then the lumbar, thoracic and cervical fibers, whereas the spinothalamic tracts, they are organized in opposite way. So most medially there is a cervical, then thoracic, lumbar, then the sacral fibers. Pain originating from nociceptors in the deeper somatic structures such as muscles, tendons, bones, periosteum, internal ligaments, etc. is the deep pain. It differs from superficial pain by nature of pain evoked by the stimuli, which usually dull aching with a poor localization. This is mainly due to the deficiency of A delta fibers in the deeper structures and the relatively less number of receptors in the deep structures. Like visceral pain, often deep pain is associated with autonomic symptoms, as autonomic fibers accompany the neurons originating these deeper body structures. Pain from deeper body part is usually accompanied by contraction of surrounding skeletal muscles. Prolonged contraction of these muscles induces muscle ischemia and aggravates the pain. The pain originating from the visceral structures is usually aching, the quality, or sometimes maybe burning, as a case of peptic ulcer, or anginal, where in case of coronary ischemia. Okay, so these are called as visceral pains. However, if intense, pain may be sharp or penetrating type. Usually, visceral pain is diffuse in nature and poorly localized and associated with autonomic symptoms. Visceral pain often radiates or referred to other structures. The receptors for visceral pains are similar to nociceptors in the somatic structures, but the receptors are much less in number. Due to the paucity of nerve endings in the viscera, the margins of the painful zone are not well delineated and the pain is poorly localized. The stimulus for visceral pain is usually the distension of the organ, if it is a hollow viscus, and chemical irritation or ischemia can also cause the visceral pain. Afferent fibers carrying the pain sensation from viscera reach the CNS via autonomic fibers. The cell bodies are located in the DRG and homologous cranial nerve ganglia. The cranial nerves that carry visceral pain fibers are vagus, glossopharyngeal, and facial nerves. Visceral pain from esophagus, stomach, and intestine and proximal colon are largely carried by the vagus nerve and terminate in the nucleus tractus solitarius before projecting to thalamus. The pain fibers from abdominal viscera also accompany the sympathetic fibers. Therefore, visceral pain is associated with autonomic features like sweating, alteration in the blood pressure. Pain fibers from pelvic structures accompany lumbosacral roots. The trigeminal nerve carries the sensation from the face and eye. Then ascending pathway. From the spinal cord, fibers travel along the lateral spinothalamic tract, the same pathway as that of somatic sensation. From thalamus, fibers project to the cortex via thalamocortical radiation. In the cortex, the representation of visceral structure is poorly organized, and the cortical areas for visual sensation are intermixed with the somatic areas. The special characteristic of visceral pain are, as the pain receptors are less in number in the viscera, the visceral pain is poorly localized. The important stimulus for elicitation of visceral pain is distension of viscera. Inflammation of the viscera also increases the sensitivity to pain. Visceral pain is usually unpleasant because it has an affective component, and the afferent fibers stimulate the ometic center in the brain. Visceral pain is usually associated with autonomic symptoms like change in the blood pressure, sweating, because of the afferent fibers travel in sympathetic and parasympathetic pathways. Thus, visceral pain causes autonomic changes. Visceral pain causes muscle spasm and rigidity, especially the abdominal pain. It is especially observed if the inflammatory process that produces pain also involves peritoneum. The muscle guarding, that is abdominal wall rigidity, is seen in acute abdomen, is a protective mechanism that prevents further injury to the viscera. Visceral pain often radiates to the other structures, which is called as referred pain. So coming to referred pain, the visceral pain may be referred to the somatic structures that are located away from the viscera. The pain perceived in the somatic structure due to the visceral irritation or injury is called as referred pain. Usually, the visceral pain is not referred to the skin overlying viscera, but to the other areas of the skin innervated by the same embryonic spinal segment. For example, the referred pain is typically seen in acute myocardial infarction or in acute cholecystitis. In acute myocardial infarction, pain is referred to the inner aspect of the left arm, and in acute cholecystitis to the tip of the right shoulder. In cholecystitis, the inflamed gallbladder irritates the diaphragm, which stimulates the phrenic nerve. Therefore, cholecystitis pain radiates to the tip of the shoulder as the shoulder and diaphragm develops from the same dermatomal segments. There are different theories for the explanation of the referred pain. Dermatomal theory, convergence theory, facilitation theory, and experience theory. Dermatomal theory. Visceral pain is referred usually to a structure that develops from the same embryonic segment, that is the dermatome. So this is called as dermatomal theory. For example, heart and the inner aspect of the arm develop from the same embryonic segment. Therefore, the pain of acute myocardial infarction radiates to ulnar border of the left arm. Then convergence theory. The visceral and somatic afferent fibers converge on the second order neuron in the spinothalamic tract. As the number of second order neurons is less than the afferent fibers, that is the first order neurons, therefore the fibers carrying the pain sensation from the somatic structure also carry the pain sensation arising from the visceral structures. The cortex sometimes cannot differentiate the site of origin of the pain sensation because of the ascending fibers projecting to cortex from both structures are same. Therefore, the signal conveyed by brain for the perception is also referred to the somatic area in addition to the projection to the viscera. In facilitation theory, the collaterals arising from the visceral afferent fibers project to the spinothalamic neurons that receive afferents from somatic structures. Therefore, pain sensation arising from the somatic structure is facilitated by the activity of visceral afferents. Thus, the minor activity in the somatic afferent can cause pain. Then experience theory. Experience plays a role in the genesis of referred pain. According to this theory, pain is instead being felt as its usual site. It may be referred to the some other structures or area in which patient had an experience of pain earlier. For example, pain due to the inflammation of the abdominal viscera is usually referred to the midline, but in patients with previous history of abdominal surgery, the pain is referred to the surgical scar, which may not be in the midline. Okay. So this is the convergence theory of the referred pain. Note that due to the convergence of the fibers of both somatic as well as visceral structures on a single second order neuron transmitting the pain sensation from somatic structure and also carry pain sensation. So that is why brain is going to perceive whether the pain is coming from somatic structure rather than the visceral structure. Then in facilitation theory, the visceral pain sensation, it also gives a collateral to the somatic pain pathway, and it is going to facilitate the activity of this particular pain pathway, and even trivial sensation from the somatic structure, it is going to facilitate the pain sensation. Then mechanism of pain, that is recognition and perception. The nociceptive stimuli damage the tissue which are recognized by the body as sensation of the pain. Proteolytic enzymes are released from the damaged tissues. These enzymes act on the tissue proteins and cells locally to release many substances that activate nociceptors. Chemical substances that mediate pain are histamine, prostaglandin, serotonin, kinins, and other polypeptides like leukotrienes. Locally released potassium ions from the damaged cells also can activate the nociceptors. Activation of nociceptors directly release polypeptide mediators by the primary afferent fibers that sensitizes nociceptors. The mediator is the substance P released from the C fiber endings of the skin. The substance P enhances the pain perception. Substance P also mediates the other features of inflammation as well. Then modulation of the pain perception. The threshold for pain perception may be same in all, but it is lowered in inflammation. Local anesthetic may centrally acting analgesics local anesthetic and many centrally acting analgesics, and also placebos act by raising the pain threshold. Distraction that turns the attention away from the painful part of the body decreases the awareness to the pain. And strong emotion also decreases the pain sensation, probably by acting on descending adrenergic system. However, the degree of emotional reaction varies in individual. The conscious awareness of pain can occur when the impulses reach the thalamocortical level. Recognition of the noxious stimulus is the function of the thalamus, and the appreciation of intensity, localization, and discrimination are the functions of the sensory cortex. So here the diagram which is showing the different types of substances which can stimulate the nociceptors. Whenever there is an injury, so there will be release of proteolytic enzymes and the histamine release, histamine, bradykinin, serotonin, prostaglandins, the potassium. Okay, so they all have a ability to stimulate the nociceptors. So this is all about the pain sensation. Thank you.